of COVID. Another thing I'll mention in terms of COVID is that during the pandemic, we saw a higher rate of traumatic birth and greater impairments in bonding overall. So there's probably a lot of factors that go into this. One of them not having your support person involved or present during the delivery. Also, maybe not as adequate of nursing care during the delivery, which is something we've heard from a lot of moms. So just really keeping in mind that we know that rates of impairment are on the rise, and rates of traumatic birth are similarly on the rise. So I want to kind of highlight some research within attachment and PMADs. So research indicates that women with PMADs are at increased risk for impairments in bonding, as maternal mental health issues can affect the mother-child relationship. Maternal fetal bonding has been shown to relate to postpartum depressive symptoms and continued impairments in bonding. So again, mothers that don't feel connected during the pregnancy itself actually go on to experience impairments in the postpartum period. So that's another reason we should just be aware and sort of taking note of these things. So this is something that, maybe OB or, an OB or outpatient therapist might take note of, the mother really not feeling connected to the pregnancy, something to look out for when the patient's going into the postpartum period. Treatment for PMADs leads to significant improvements in mother-child relationships. So the goal really is to enhance treatment resources for women that are experiencing PMADs and show support for women that are experiencing these impairments, right? We know that treatment works, and decreased mental health symptoms also are related to improvements in bonding and connection. Perinatal women seeking mental health treatment during COVID demonstrated higher rates of PMADs as well as greater rates of impairments in bonding. So again, similarly, we want to just contextualize all of this within COVID and the pandemic, that we know more and more women are reporting PMADs, as Paige earlier mentioned, and there are greater impairments in bonding and connection. So something I want to kind of highlight as well is societal expectations for women, right? So a lot of what I hear is women talking about feeling an intense pressure to feel connected and bonded to their baby, right? So we hear things all the time like, I instantly feel connection or love towards my baby, or people saying you're so lucky, or this is such a gift, right? Or other, hearing other moms say, I love my baby to bits. I couldn't imagine my life without my baby, right? So there's a lot of pressure for women to feel this way. And if you don't feel this way, there's a lot of shame and guilt that you can experience, right? So this idea of like, why don't I feel that this is the best moment of my life? Why don't I feel connected in the way that I expected, right? So it really can attribute to worse, sort of mental health outcomes and feeling more and more disconnected, right? Feeling like this is never going to happen for me. So a lot of the work is kind of normalizing that this isn't something that happens instantaneously, right? It's something that takes time. And this is a relationship that's forming over time. So there's a lot of pressures we hear all the time from moms to be the perfect kind of mom. And it's seen to be related to, perfectionism has been found to be related to increased parenting stress, as well as maternal gatekeeping behaviors. So moms not wanting others to care for the baby, feeling like they're the only ones that can get something accomplished or done with their baby. And so that can also heighten distress around caring for baby, right? And make it feel overwhelming for the mother. So I want to talk a little bit about how to assess for some impairments in bonding, and how to really think about approaching these things in intakes with patients, right? So this is kind of our port of entry. I often think of intakes and evaluations as opportunities to make recommendations for Diatic treatment, right? So it's sort of the first time we're meeting a patient, we're getting to know their story, we're learning about what their experience has been so far in the pregnancy, in the postpartum period. And we're getting a sense of how they relate to their infant or how they relate to their unborn child if they're pregnant, right? So some things I want people to consider, and I always kind of consider when I'm going into an intake, are mentions of fear and worry around the baby's well-being. So a lot of times moms will describe intense preoccupation with feeding, for example, or worries about if the baby will be hurt or injured, right? So some of those intrusive thoughts, right? What if someone drops the baby? What if I trip while I'm holding the baby? Also, any mention of early separation. So if there was inpatient hospitalization for mom, right? There was some kind of separation that happened, or a NICU stay, right? So maybe baby was in the NICU for several weeks, right? That significantly contributes to their ability to connect or feel connected to the baby. Whether or not the pregnancy was planned or unplanned, right? So major important question to ask, right? Was this a desired pregnancy? Was this anticipated, right? How did you feel when you found out that you were pregnant? Did you experience any fertility challenges? Another major one, right? So did you go through IVF treatment? Have you experienced any perinatal losses, right? Had you had any miscarriages, right? We know that these are things that really significantly impact connection and bonding. And then also any discussion of limited contact with baby, right? So sort of moms that say, oh, I have a caretaker or I have a nanny that watches the baby. I don't really kind of interact with the baby, or I feel nervous to interact with the baby, or I feel overwhelmed interacting with the baby, right? So these are some things to kind of keep in mind as well. So in terms of screening, there are several screening tools that we can use and have been really emphasized and utilized in the field. So the one we use, and the one that I kind of use in my private practice as well, is the postpartum bonding questionnaire. Now, this is a 25-item scale designed to assess the mother and child relationship. It was developed in 2006, and patients are asked to respond to a series of 25 statements related to their feelings or attitudes towards their babies, right? So it contains 4 subscales: impaired bonding, rejection and pathological anger, infant-focused anxiety, and incipient abuse, right? So we're really assessing for how the mother feels when they're interacting with their baby or caring for their baby. And one of the most important scales, or the one that I pay a lot of attention to at the very least, is the impaired bonding score. So scores above 12 on impaired bonding are considered clinically significant, right? So there's something going on within the relationship that we want to take note of and we want to emphasize. These are patients that we might really strongly consider for a Diatic treatment or an attachment-focused treatment of some sort. Some additional screening tools I'll mention are the screening for pregnant women, or the maternal fetal attachment scale. Both of these are actually measures of attachment in pregnancy, right? So this is really interesting, and not a lot of people administer these, as far as my understanding goes, but can be really essential, right? Sort of understanding how well the mom feels connected to the baby even before the baby is born. And then some other postpartum screenings include the screening for postpartum women, mother-infant bonding scale, and the parent-to-infant attachment questionnaire. So other assessment measures to consider and think about, and these are some highly validated measures that I want to mention, are the adult attachment interview. So the adult attachment interview is a structured semi-clinical interview which aims to assess early attachment relationships and their implications on adult personality, right? Developed by Mary Main. And the goal really is to understand the relationships that the patient has had with their caretakers, right? So this isn't a pure assessment of infant-parent relationship, but it does very greatly inform how a parent might interact with their baby or children. So participants are asked to reflect on 5 adjectives to describe their relationships with their caretakers growing up. In addition, experiences surrounding separation and loss, as well as um, traumatic events or experiences of rejection are assessed, right? So in understanding a patient's history or experiences with their caretakers, we can kind of get a sense of what it might be like for this patient as a parent, right? So how they understand their early relationships very much informs how they might interact now. One of the most critical questions that I think is so essential, and I often ask parents, is when you were upset as a child, what would you do? So some parents may say, I cried alone in my room. Some parents might say, I felt like my parent was there, they would give me a big hug. And those are two very different responses, right? So if someone's responding and sort of reflecting on feeling like they were left alone or they didn't have a way of expressing their emotions, we could imagine it might be tough for them as well to be there in that way for their child, right? So something to just consider, although it's not always the case, it can very much inform how they might behave or respond to their newborns. Some clinical implications: the AAI is both used as a research tool and a clinical tool, which can aid in conceptualization and enhancing dyadic-oriented treatments, right? It can really inform the treatment itself and guide you in how you think about the patient. Another assessment tool that I very often use is the Adverse Childhood Experiences Questionnaire, which is a tool used to assess 10 categories of trauma, neglect, and household dysfunction. The implementation of the ACE measure can really inform your treatment, right? So patients that are reporting significant childhood abuse, right? We want to know about that. We want to know about how that might affect how they feel as new parents, how they might feel going into a relationship with their child or becoming a mother for the first time. And we know that higher rates of ACEs have been shown to relate to higher risk for mental health issues in adulthood, and actually have also been linked to insecure attachment in adults. So people that have higher rates of ACEs are also more likely to show insecure attachment in adulthood. And parents with higher ACEs also demonstrated lower rates of reflective functioning when it came to their own children. So parents that experienced trauma essentially had a harder time mentalizing or considering their child's experience, right? Holding the mental states of their children in mind. So obviously really, really important stuff we want to consider and think about when we're treating patients with high ACEs is how it might affect their ability to really reflect on their child's experience, right? So these are some really important pieces. So just to continue on in terms of the ACE measure, these are some categories that are being assessed, right? We have abuse by category, so emotional, physical, and sexual abuse, neglect, which includes emotional and physical neglect, in addition to household dysfunction, right? So if there was domestic violence in the household, separation or divorce, history of maternal or maternal mental health issues, substance abuse in the home, or having an incarcerated household member, right? So when we think of trauma, we think, oftentimes think about abuse or neglect, but we fail to neglect these aspects of household dysfunction. For example, having a parent with a mental health difficulty. Okay, so I want to move on to really talking about how we're treating the parent-infant relationship through dyadic work. So when we talk about dyadic treatment, what do we mean, right? So a lot of times people ask me this sort of like, what do you even mean when you talk about dyadic treatment? What is that, right? So dyadic treatments aim to foster attachment relationships and enhance bonding between children and their caretakers, right? And one of my former supervisors described it the best, which is the idea that the patient, when you're doing dyadic treatment, is neither the adult nor the child. It is the relationship itself, right? So the idea is you're very much treating the relationship working with a mom and a baby in the moment, in vivo, making observations about those interactions and helping the mother really reflect on the child's experience. So mothers demonstrating significant impairments in bonding as assessed at intake may be considered for dyadic treatment, which really emphasizes increasing mentalization capacity or reflective functioning and facilitating interactions between mothers and their babies. Literature suggests that treatments which focus on relationships between postpartum mothers and their infants led to significant improvements in overall mental health symptoms, as well as self-reported mother-infant interactions, right? So as we treat mothers with postpartum depression, anxiety, we see that there is improvement in the relationship itself, right? Perinatal women who participated in a randomized control trial for what we call perinatal Diatic psychotherapy similarly showed marked improvements in postpartum depression, as well as overall kind of connection and bonding with their infants. So how do we introduce dyadic treatment in the first place? So a lot of people will ask this question, sort of like, what is this treatment? Why are we recommending it? How do we introduce this to patients? We often interact with patients that are, really ambivalent about doing a dyadically informed treatment or being in treatment in general with their baby, right? So some people we might consider for a dyadic referral are mothers that are expressing impairments in bonding, again, using our PBQ measures or other assessment measures, mothers with significant trauma histories, for example, using the ACEs, limited independence or autonomy in caring for babies, so mothers that are really struggling to independently care for their babies, or mothers that are really struggling to separate from their babies, right? So sometimes we can kind of think about mothers that are, we call very attached, right? So mothers that are wanting to be with their babies all the time. And we often think of that as a good thing, right? But sometimes there can be some downfalls there, right? So maybe moms that are struggling to allow others to care for the baby or give them breaks, feeling very fearful in separating from their babies. So these are actually moms that might be a good fit for a dyadic focused treatment. So when we're making these recommendations, we really want to emphasize the fact that the goal of dyadic treatment is to strengthen an existing relationship between mothers and their babies, right? So by telling a patient, the goal of this is really to improve your relationship, to really promote and really strengthen the relationship, and to also increase attunement, right? So allow you to better understand your baby, right? And to be more attuned to what they need from you. I often also like to normalize the connection between PMADs and impairments in bonding. So by telling mothers, it's very common for women that are experiencing PMADs to have some difficulty connecting, right? That makes sense. That's so understandable. And also increasing caretaker confidence, right? So sometimes I like to kind of market it as a way to feel more confident in caring for your baby or to better understand your baby in receiving some psychoeducation about child development. So this can be a helpful way to sort of explain it to patients or kind of like broach the topic of a referral. So some evidence-based treatments that I wanted to mention, I won't go into detail with these, but just for people to have as a reference point, and I included these in the reference page, but we have attachment and behavioral catch-up that was developed by Mary Dozier, which is a 10-week home visiting program, which aims to support parents with children from 6 to 24 months. And it really targets children who have experienced early adversity. And the goal is really for parents to be coached by a clinician in in-person sessions and to enhance nurturance, self-regulation, and attachment, right? So the goal is really to help parents support their children and walk them through this. So there's a real kind of coach mentality in this treatment. There's also child-parent psychotherapy, which a lot of other treatments are based off of, which was developed by Alicia Lieberman. And this treatment was developed for children from birth to 5, and the treatment targets children at risk for insecure attachment, with the goals of enhancing attachment security, promoting partnership between parents and their children, and enhancing exploration and learning for children, right? So the idea here is to really promote the relationship. And I like the word partnership that they use, right? The idea of the parent and the child being a partner in that relationship and working together to increase security and exploration. Another treatment that I hold very dearly, I actually helped to kind of administer some of the assessment protocols and the RCT of the group attachment-based intervention, which was developed by Anne Murphy. And this is a 26-week group-based program, which treats parents and children from birth to 3. So this is a longer kind of term program, which is really aiming to treat families at risk for maltreatment. So a lot of the patients that are referred to Gabby are, mothers who are really struggling or parents that are really struggling, many of which are kind of higher risk in many capacities. So are known to ACS, for example, have preventative care involved. And the goal really is to promote secure attachment. And they use this rearing concept, which I really love and I often reference, which is really highlighting these main points within the treatment. So reflective functioning, emotional attunement, affect regulation, reticence, intergenerational patterns, nurturance, and group context, right? So the idea is really promoting mentalization within the parents, allowing for the parents to be more attuned to their babies, allow them to know how to handle moments in which their babies might be in more distress, right? And to sit back, right? Reticence to sit back and observe their babies in certain ways and be able to allow their babies to figure it out or explore. So I realized at the time, so I'm going to go through some themes that I think are really important within the Diatic work, and then I want to move to some questions. But some themes to keep in mind, things that come up a lot in Diatic treatment, this concept of good enough mothering. For those of you that know Winnicott, right, he really talked about this idea of achieving good enough parenting, right? So being attuned to our babies a portion of the time, and recognizing that these moments of rupture and repair will happen where we are not always able to be attuned to our babies, and that's okay, right? So this is something I really bring up a lot with maybe our more perfectionistic parents that feel like I have to get it right all the time. I have to be attuned to my baby at all times, and really reminding them that this is sort of a give and take process, that relationships are not one-sided, and that there are these moments of rupture and repair where we might miss something, we might not pick up on a cue, but we can kind of learn from it, right? We can do something different next time. And that actually, that rupture helps babies too, because it allows them to kind of figure it out, right? And be a little bit more resilient. So I really come to this concept a lot, the concept of good enough mothering. The other point I mentioned quite a bit in the presentation was mentalization or reflective functioning. So Peter Fonagy introduced this term, mentalization. And what he really was referring to is the ability to consider the mental states within ourselves and the mental states within others, right? So when it comes to Diatic work, we're really emphasizing that parents, we want to encourage parents to really be thinking about what their babies might be feeling, what their babies might be doing, and why, right? So understanding kind of like what's going on for the baby. What are they thinking about? What are they doing? And the thing I want to mention here is that sometimes we can see that mothers or parents in general might project a lot onto the baby, right? They might sort of assume intentions from the baby. The baby's trying to bother me. They're being kind of they're misbehaving. They're pushing back. right, they might project certain things onto the baby. So it can help moms to really think about it in a different way, to be able to sort of say like, what else might be going on for the baby right now? Why else might they be crying? Or why might they be reaching for us, right? So enhancing that kind of reflective functioning or mentalization is really important. The other piece, which is kind of self-explanatory, is attachment and bonding. So the goal is really to establish a relationship, secure attachment between the mother and the baby, encouraging interactions between the mom and the baby. So supporting moms that may feel more apprehensive in interacting with their babies, and also encouraging play between moms and babies. So this is something that cannot be underestimated, how important it is to have these maybe more downtime moments where moms are just connecting or playing with their babies. And sometimes the clinician can actually sort of be the one to get down on the floor with the babies and interact with them as well. Some other themes I want to mention: separation, individuation, from Margaret Mahler, and object relations. And object relations from Melanie Klein. So when we think of separation individuation, we're really thinking about this kind of exploration individuation process where the babies are moving away from the mother, right? So the babies are exploring their environment. They're learning about themselves in a different way, what they like, what they dislike. And in terms of object relations, seeing the baby as a subject versus an object, right? So the baby has an individual self, a mind, wants, desires that are separate, or that are separate from the mother, that are not necessarily connected to the mother, right? So really thinking of the babies as little people, right? Little individuals that have minds that we can kind of aim to understand or want to be curious about. And the last 2 points I want to make are that we speak a lot in the Diatic treatment about transition into motherhood. So the idea of role transition, right? So I'm kind of taking on this new role as mom. So how do I integrate the baby into my existing life, right? And a lot of moms really struggle with this, the idea of how to integrate. And also just knowledge and understanding about child development, right? So sometimes it can be an opportunity to really explore, like, where is the child in their development? What is expected at this age? What can we anticipate? And then the last piece I wanted to mention was this idea of intergenerational trauma. And of course, I want to be very mindful of doing exploration around trauma with patients that I might be working with in a shorter term model. So this is really maybe more so for longer term kind of psychotherapy treatment, where we want to understand the impact of early relationships on our current relationships with our babies. And a lot of times moms will report limited modeling, feeling like, I didn't really learn about how to be a parent. So this is a really tough thing for a lot of parents. So I want to jump to questions, but I also just wanted to highlight, and we will share these slides with everyone. These are some book recommendations for people to check out if they're interested. And I want to kind of I'm going to stop my share and turn to questions because I see quite a few questions in the chat. So the first one I see is, can you talk a little bit about attachment going back to work? So I think that's a really great question, and something that we kind of deal with a lot within our partial hospitalization program is this idea of sort of return to work. What will this be like for me? And a lot of times moms will express kind of feeling some relief around return to work, actually, because this kind of feeling like I can get this part of my identity back. So sometimes it really is sort of about how to integrate these different roles, right? So my role as an employee, for example, versus my role as mom, right? And sort of exploring with patients too, like how it feels to go back to work, how difficult that must be for both them and their baby, right? So a lot of it is sort of an easing in process, right? So is there a way for them to maybe have their baby in daycare, as a trial run for half days before they go back, right? So are there ways that we can kind of ease this transition? Thank you for that question, Rebecca. I'm going to go to Michelle, and I think there are a couple of questions in here, but the first one was, what screeners would you recommend if consulting with PMADs on a NICU or high-risk OBGYN? It's a really good question. I listed in there in the PowerPoints a couple of measures that are very commonly used. So I really want to emphasize the PBQ, which is a very commonly used measure, the postpartum bonding questionnaire. And this is absolutely something that you could utilize and administer in a NICU or OB setting. This is very, very much in our clinic, we very much administer this with the EPDS. So a lot of people are familiar with the Edinburgh scale. So this is another measure that you can easily administer. A self-report, it takes someone about 5 minutes to complete. So I really, really emphasize administering these measures to patients as much as you possibly can, because this is something we might miss out on otherwise. Okay. Another question for Michelle, postpartum women, for postpartum women who also experienced a trauma and are triggered or dysregulated during intake, what tips might you suggest to help them focus on assessments, or would you recommend emotional support in building an alliance first? So this is completely up to you, really very much patient dependent. But if you're getting the sense that patients are feeling overwhelmed, you might want to kind of pull back from maybe a more standard assessment, checking in with the patient. But I think, assessment can be part of the protocol, right? So the idea of sort of administering it at the outset, right, to sort of get it in, be able to have it as a reference point can be really helpful. But I've often also completed these measures with patients as well, right? So I've walked them through the measures. I've taken breaks when I'm administering these measures. So it's really up to you in terms of how you approach it. Another question, I hope I get to everybody, is do you have any resources on attunement to babies, child development? Please also post resources on the Motherhood Center has. So I will absolutely talk to Paige about this one, and maybe we can post some resources specific to child development that might be useful. And I think there's tons and tons of really great resources out there. One thing I really like oftentimes is 0 to 3, which is a resource that is free and accessible. And it has a lot of cool recommendations in helping promote attachment and helping promote mother-infant interaction. So I really would look into that 0 to 3 as a resource. It's a great one. In your experience, how can physicians begin to better identify and address issues of paternal responsiveness in primary care? So again, I think screening is such a key aspect of this and really understanding how this might be playing out within the relationship. Of course, I understand in primary care settings, like time is very limited. So this is a measure, again, administering a measure, for example, with intake paperwork is a great, great option. There are clinics that are doing this. One of them is Montefiore Medical Center has a program which they are very much administering ACE measures, for example, at intake to really get a sense of how moms are doing, what factors might be contributing to the connection and bonding. But I really emphasize doing this at intake, really before you even meet with the patient. You could have them fill out some of these forms and make referrals accordingly. Okay. Vanessa, from a prescriber perspective, I find that perfectionism is a prevalent theme. Absolutely. Aside from supportive therapy with good enough mothering, how else can we support mama? So this is really such a super, super common theme that comes up. We talk about it a lot in our program, and I think it's a complex one, right? Because I think one of the things that I really emphasize is the fact that mothers are doing their best. They're really trying as best as they can to support their babies and to be the best moms that they can be. But I also like to point out when things really tip into feeling unproductive, right? If the mom is really struggling, for example, with sleep, right? Or they're not really taking care of themselves, they're not showering, right? It can be an opportunity to really point those things out, right? To be able to say, I understand that you want to be the best mom you can be. And also, you know, we want to make sure you're okay too, right? You being okay is also going to help your baby, right? So that's kind of a quick and dirty way that I often approach that. Okay. Madeline, I see question about impact of infant sleep. I think that's such a important, really, really important question. So we absolutely see a relationship between sleep, PMADs, and attachment, right? So moms that are not getting adequate sleep are certainly not feeling like they have as much space to take care of their babies or to be attuned to their babies, right? So the idea is sort of if you're not sleeping, if you're not taking care of yourself, to that similar point, you're often also, maybe feeling more frustrated with your baby, feeling like the baby's not, I've heard this very commonly, like my baby's kind of like bad, or, there's something wrong with my baby. Why aren't they sleeping? Right. So absolutely, infant sleep can be related to attachment and PMADs as well. We want moms sleeping. We want moms taking care of themselves. And I think it's interesting when it comes to sleep choices, right? Of course, this is not a one size fits all model. And, we want to encourage moms to do what they think is right. But, certainly lack of sleep has a really considerable effect. So I'm going to try to get to everyone in the short time we have left. I see Kathleen, you touched on this a bit with good enough mothering, but I see a lot of anxiety around attachment parenting. Yeah, and high bar that it sets. Worry that not following the parenting model perfectly will rupture the attachment. How do you handle these questions? So, Kathleen, such an amazing question. I think this comes up so much. And I do want to differentiate a little bit attachment theory from attachment parenting. So when we think about attachment, we're really often thinking about this rupture repair model, like this idea that, there is no such thing as a perfect parent. There is no possibility to be attuned to your baby at all times. And it's not actually so great in terms of outcomes for our babies, right? So the idea is like we want our babies to kind of be resilient in certain ways and know that like their needs won't always be addressed, right? But there's certainly a really high bar. I heard that even today in our group, right? We actually heard that just today in our group, the idea that I feel so much pressure to get it right with my baby and to establish a secure attachment to the point that I feel actually disconnected, right? Or I feel so burnt out. I don't have room or space for myself. So this is something that comes up quite a bit. And really, I think I really like to emphasize the fact that these ruptures and repairs are normal parts of life and are important for child development, and actually strengthen relationships, allow for communication to occur. I think the next one I see from Felix. Okay, I'm glad it was a helpful presentation. One of the things that you mentioned are what are the interventions for mothers who are unconsciously transferring the spillover effects of their childhood traumas on their children? I think that's a great question. One of the interventions I mentioned, the group attachment-based intervention, is very much steeped in attachment literature and in trauma literature, as well as CPP, which is child parent psychotherapy. A lot of these interventions are actually aimed towards mothers that have experienced trauma themselves, because we know that these mothers or parents or fathers are at higher risk, right? So we know that this is the case. And that's why a lot of the treatments that have been developed to treat mothers and infants are targeted towards parents who have experienced earlier trauma. So actually that is like sort of more of the common theme that we see. I know we're about out of time. I don't know if there's any other questions that I see. There's a lot in the chat as well, but I know that we're almost out of time. I like, Celine, what you're saying. A lot of new moms who are perfectionistic, trying to focus on good enough mothering. Absolutely. So I think just sort of really want to thank everyone for being present today, asking questions. I'm really glad that people have so many questions. I hope I got to everything, but if not, people can feel free to contact me with any questions. I think Shannon might provide my email to anyone that wants to connect at all. And we will also be able to share these slides. So to someone's question. And I think, Colin, another just quick question, recommendations of explaining rupture repair. I think really kind of as much as I can, I go to Winnicott. So if people are not familiar with those readings, I would really very much encourage it. So I think that might be all we have time for today. If people have other questions, feel free to reach out. And Shannon will also be sharing the slides. Thank you, everyone.